Reminder. All right. Good evening, everyone. I'd like to welcome you to this evening's G-EHCO, which is, as you know, hosted by the Gastro Foundation in association with Project ECHO from the University of New Mexico. As you're also aware, G-EHCO Fellows is run every second Monday, starting at 6 p.m. in the evening, as Karen has just pointed out, on a timely manner. So today we have Dr. Rahm Makan from the University of Free State. He's going to be talking to us about acute pancreatitis. The chat is open, so please put your questions in there. I will be keeping an eye on the chat, and I will hopefully have a lot of questions that I can relay on your behalf. If there's a very complicated question, I may ask you just to unmute yourself and ask the question. So without further ado, if I can hand over to Rahm, you may share your screen.
Good evening, everybody. Let's just confirm.
Yeah, we can see it. Perfect. There you go.
Okay. All right. Good evening. We're speaking about acute pancreatitis today. Just want to thank Professor Brand for your encouragement during the development of this presentation. So let's go. Acute pancreatitis has an incidence of 20 to 40 per 100,000. This is European statistics. And there's been noted to be a rising incidence due to increased alcoholism and the increased incidence of obesity, and then that leads to gallstone formation. So the definition of acute pancreatitis is you need 2 out of 3 of these. So symptoms is consistent with acute pancreatitis, which is your epigastric pain, left upper quadrant pain radiating to the back. And then a laboratory test like your serum amylase or lipase, with the lipase being greater than 3 times the upper limits of normal. Or you can get radiological imaging that's consistent with pancreatitis. So the risk factors for pancreatitis is obstruction, and typically from gallstones, which is 40 to 60%. Can also be caused by parasites, tumors, and an annular pancreas. Alcohol makes up for about 30% of cases, and other toxins and drugs. Metabolic causes, hypertriglyceridemia with diabetes and hypercalcemia. Infections can also cause pancreatitis, as well as vascular disorders like vasculitis, emboli, hypotension. Trauma, post-ERCP is also a risk factor. There's genetic causes, as well as sphincter body dysfunction and smoking. So the genetic causes are your mutant trypsins, which are R122H and N29I genes, your CTFR, which is your cystic fibrosis gene, and then SFINC1 mutations that can cause pancreatitis. So there's a long list of drugs that can be associated with pancreatitis. So one should always screen the patient to see if the patient's on any of these drugs, if you have a patient with pancreatitis. So the pathogenesis is where trypsinogen is converted to trypsin within the acinar cells by the trypsin activation protein. So trypsin then catalyzes the conversion of proenzymes into active enzymes, and these enzymes are elastase, phospholipase A2, and carboxypeptidase. So once these enzymes are activated, they then auto-digest the pancreas, and they result in the release of more of these enzymes. And with this, the complement system and kinin systems also get activated. So these mechanisms, this release of enzymes then overpowers the trypsin inhibition mechanism. So these mechanisms fail. So these mechanisms are unable to inhibit trypsin. And some of these mechanisms are the SFINC1, the mesotrypsin, enzyme Y, and then trypsin itself inactivates trypsin, and then alpha-1 antitrypsin, alpha-2 macroglobulin, and then pancreatic enzymes also sequestrated within compartments in the acinar cell. And low intracellular calcium levels also inhibit trypsin. Okay, so then once the cells are activated or injured rather, there's a cellular pathway of injury, and that attracts more local inflammatory cytokines like your TNF, platelet activation factor, and interleukins 1, 6, and 8. So these lead to microcirculatory changes within the pancreas that leads to ischemia and edema. So the disruption of the pancreatic ducts during this whole process leads to fluid collections that are formed. And then also, these pancreatic enzymes can be released into the portal circulation, which then have systemic effects. And one of them is that acute respiratory distress syndrome is caused by phospholipase A2, which digests the lung surfactant. Alcohol, so the mechanism of alcohol is a necrosis fibrosis sequence from recurrent and subclinical bouts of pancreatitis. So the patient may not always be symptomatic for pancreatitis, but may have subclinical bouts of pancreatitis, and it happens in a recurring process. Also, alcohol is directly toxic to the acinar cells, and then it also leads to oxidative stress from free radicals. Another model is the sentinel acute pancreatitis event, where there's a two-hit model where there's an acute factor in addition to an underlying predisposition. For example, the acute factor can be the acute alcoholic bout that then leads to pancreatitis. So the clinical presentation is epigastric pain, right upper quadrant pain, usually a rapid onset with no relieving factors, and the patients describe it as being unbearable, steady pain. They often present with guarding and distension from ileus as well. And then you may get your Gray, Turner, and Cullen signs. There also may be an epigastric mass palpable if a pseudocyst has developed. Depending on severity, the patient may be hemodynamically unstable. And you may also have to deal with delirium from the alcohol withdrawal if it was due to alcohol. So here is an image of Cullen sign and Gray Turner sign. Cullen sign periumbilical and Gray Turner's on the flanks. So the differential diagnosis for acute pancreatitis can be biliary cause, biliary colic, acute cholecystitis, a perforated hollow viscous, mesenteric ischemia or infarction, intestinal obstruction, a myocardial infarct, an aortic aneurysm that's dissecting, and an ectopic pregnancy. So acute severe pancreatitis is associated with a very high mortality. But reassuringly, about 80 to 85% of the patients that we see have mild disease. The problem is with the other 20% who have risk of a high mortality, to accurately predict who is going to have severe disease so that we can then monitor those patients more closely for complications. So when we see the patient, our first concern is to determine is organ failure and extensive necrosis. So part of that is to obtain imaging, and if we see interstitial pancreatitis, it most likely would be mild. And if we start seeing necrotizing features, then we know we're dealing with a severe case. Part of the management is fluid resuscitation, but we'll speak about that further. And then if you can determine a cause, you want to address that cause. So these are features that you can look at in your patient to see if your patient is at risk of having severe disease. So obesity is one of them. If there's evidence of systemic inflammatory response syndrome, and then if you have elevated urea and renal impairment, as well as on imaging, if you start seeing pleural effusions and signs of ARDS with pulmonary infiltrates, and if you start seeing collections as well. So there have been scoring systems that have been developed to assess this. The revised Atlanta classification is what's currently being used in the literature. And there's also an Apache 2O, which the O stands for obesity, which accounts for the patient's BMI. There's also the BICEP score, which is a bedside score. There's a CT scoring system. And if you just have an X-ray available, you can, if you have bilateral pleural effusions, that also can imply severe disease. So the Apache 2 score was the one that demonstrated the highest accuracy for the prediction of severe acute pancreatitis. The issue with the Apache 2 score is it's very technical and it can take a long time to gather all the data you need to process it. We also have the BICEP score, which is the bedside score, which is a lot simpler, and it has been shown to have a very similar accuracy as the Apache 2 score. So this is the Apache score, all the variables that are looked at in the Apache score. So the Apache 2O score for obesity includes the BMI. So basically you take the Apache 2 score and you add on the BMI score. So 0 for normal BMI, 1 for BMI between 26 to 30, and 2 for patient who's obese. So if you use Apache O score, at a cutoff more than 8, the sensitivity was 82% for severe acute pancreatitis and a specificity of 86%. The positive predictive value was 74% and the negative predictive value was 91%. And the overall accuracy was 85%. So the modified Marshall organ failure score helps us to identify which patients are in organ failure. So if you plot your patient according to this chart, and if a score of more than 2 in any organ system indicates that particular organ is in failure. So there is a Santorini consensus as well that was developed to try and look at other markers. So they agree that obesity is a factor. The pleural effusions are also a factor. The Apache 2 score more than 6, and the Apache O score more than 6 as well. And then a CRP more than 150 as well can indicate that you are dealing with severe pancreatitis. So the Atlanta classification is broken down into mild, moderately severe, and severe. So mild cases do not have organ failure. They do not have local or systemic complications. Moderately severe cases have reversible organ failure that resolves in less than 48 hours. And then they have local or systemic complications without organ failure. And severe would mean they have persistent organ failure, more than 48 hours, or an Apache 2 score more than 8. Okay. And this is to show you the bedside index for severity, the BICEP score in acute pancreatitis. So this looks at the urea, the mental status, the evidence of a systemic inflammatory response syndrome, and age and a pleural effusion. Much quicker than the Apache score. So the course of disease is characterized by an acute phase, which is the first 7 days, in which you may have organ failure or SIRS. Once again, 80% of these patients often resolve without progressing further. And then you get the subacute phase, which is 7 days and beyond, where they may have persisting organ failure from the acute phase, and then you may have the onset of complications, which is your presence of fluid collection and then infections thereof. This is just a flow chart to how to manage these patients according to their presentation on their time interval. So if you look at the laboratory tests we have available, the serum amylase rises quickly within 6 to 12 hours after the onset of pancreatitis and has a half-life of 10 hours. The serum lipase is much more sensitive than amylase, and the diagnostic cutoff we use is 3 times the upper limit of normal. Here we have the sensitivity and specificity of various tests available. To my knowledge, in practice, we still use the amylase and lipase. Trypsin and elastase are not freely available to us. Then you can go on to imaging of your patient. So when you do a chest and abdominal X-ray, you try to exclude other causes like your perforated viscus and other causes for the pain. The ultrasound is helpful in assessing for gallstones and if you have the development of a pseudocyst. The CT is also useful because it excludes other pathologies and it helps to stage the severity of your acute pancreatitis. So you can then find your edematous pancreas or necrosis thereof. And it will also help you to assess for pancreatic necrosis, which is defined as more than 30% of non-enhancing pancreatic tissue on imaging. So the MRI is better than CT because it can help to distinguish necrotic debris better than a CT. And it can also help you to assess your duct anatomy and for disruption of the ducts. So in the CT scan, we can see that there's...
Sorry, Rahm.
Yes.
Can I jump in here quickly? If you go back one slide,
Yes.
what would be your indications for a CT scan and acute pancreatitis?
Indications. So I would, if you're looking for, so if you have a patient who has organ failure and you want to then assess for if there is a presence of a pseudocyst or if there's infection or necrosis, in a patient with mild disease, you could be a bit more conservative. But I think once you start getting the signs of organ failure, and if you have raising infective markers, and then you would then want to scan the patient to see, what you're dealing with.
Okay. I agree, but I don't necessarily agree. So in acute pancreatitis, there's two time zones really where you would do a CT scan. The one is in the very acute phase where the patient has just presented. And the indications there are really just two. The one is if you've got diagnostic uncertainty. So maybe you've got an amylase or a lipase that's borderline, but the patient's had pain for a couple of days, for example. So you're not sure whether or not they actually have acute pancreatitis. It's a diagnostic uncertainty is the one. The other is if you have a patient with severe acute pancreatitis and despite supporting their organs, the patient deteriorates. So maybe it's a patient who had to be intubated. Maybe it's a patient who was started on inotropes, but they are not improving despite best medical care. Then you would need to do a CT scan to ensure that they don't have a complication because of the acute pancreatitis. Complications that we would look for are, in essence, maybe portal vein thrombosis. You also get thrombosis in the colic veins that can also give you venous ischemia of the colon. And those are some of the reasons why the patient may not get better. Otherwise, we really do avoid using a CT scan in the early phase because you may push them into organ dysfunction, specifically with acute renal dysfunction. So we are very, very, very slow to do a CT scan. Probably the most common place in acute pancreatitis for a CT scan is during the second hit, which is where we start thinking about sepsis and infected necrosis, etc., like that. So that would be a patient who maybe they were admitted with severe or moderate, they got better, and then all of a sudden, 7 to 10 days down the road, they come back, organ dysfunction again, or markers are going up, infection, and those are and that's probably the most common scenario for imaging an acute pancreatitis. But otherwise, not so much. I think there was a question. Abdominal CT without contrast in the first 48 hours. I'm not really sure what the value of that is, because remember, you do need the contrast to see the level of inflammation. If you are going to do a CT scan, you want to see the vasculature, specifically the portal vein, the SMV, the splenic vein, see if there's thromboses there. So doing an abdominal CT scan without contrast really doesn't give you much information at all. So again, unless you actually have hard indications, and if you do have a hard indication, then rather use contrast. Okay. Yeah. So So VG's comment is correct, except I would just add to it, it's the other indication, as I said, is a patient who does not improve despite best medical therapy. All right, good. Sorry for that. You can continue.
Thank you. All right. Okay, so in this CT scan, we can see there's areas of non-enhancing pancreas here, and there's also air, so that implies that there could be some secondary infection of this necrotic area. So there's also a CT grading, the Balthazar grade and the CTSI score, to look at necrosis, to assist us with this scan report. So the treatment overview, in the first week of care, it's supportive care, and you want to encourage your patient to have early oral intake, and because that maintains mucosal barrier and prevents bacterial translocation. You'd want to provide analgesia, IV fluid to prevent volume loss. It prevents acute kidney injury and pancreatic necrosis due to the extravasation of the protein-rich fluid into the peritoneal cavity, which explains why patients get the Cullen sign and Gray Turner sign. You can drain the patient if with the NGT tube if they have ileus and intractable vomiting. For ventilated patients, intra-abdominal pressure monitoring is suggested, and antibiotics is only for proven infections, but we'll talk about this again, and ERCP if there wasn't a stone in the acute phase. So if you look at the fluid restarts.
Again, if you go back to your previous slide, I think be very cautious with monitoring intra-abdominal pressure. You need to be very careful with that. The patients, it needs to be done correctly. So in ventilated patients, they need to be completely paralyzed. And it has to be done absolutely correctly because a large number of these patients will have increased intra-abdominal pressure. The problem with this, though, is what to do about it. And our intensivists, we have got a patient currently in ICU where we're having this discussion. The problem is that they don't get a true raised intra-abdominal pressure because all of this is in the retroperitoneum. So if you think about the management of intra-abdominal pressure, it's decompression from the top and from the bottom, catheters, etc. And eventually then the question always becomes, are you going to do a laparotomy to open the abdomen? But the actual pressure is in the retroperitoneum. So it's very debatable whether or not a laparotomy in this kind of a patient is of any benefit. There's significant data that shows once patients get this intractable intra-abdominal pressure and severe acute pancreatitis, a laparotomy is effectively a post-mortem. So in this situation, in these patients, be very careful about intra-abdominal pressure and also interpreting it. And then also at the end of the day, what one is going to do about it. ERCP, if a stone is identified, I don't necessarily agree with that. If we think about the pathophysiology of biliary pancreatitis, it's not usually the big stones that would normally cause, for example, obstructive jaundice. It's usually gravel and sediment. That has been dropping out of the gallbladder past a little bit of localized edema, and that's thought what causes it. So it's also very rare for these patients to have obstructive jaundice. Be very careful of an ERCP and acute pancreatitis because you can really flare up pancreatitis, and what you don't want to do is make a mild patient into a severe with a significant risk of mortality. So the only indication for ERCP is actually a patient who's got acute cholangitis at the same time, which is a phenomenally rare situation. So how do you think you would identify, or how do you think you would diagnose and has also got acute pancreatitis?
A patient post-ERCP?
No.
Sorry, what was your question, Prof? Yeah.
My question is, how do you diagnose, or how do you decide a patient needs, you know what, let me actually switch my video off, that might help. How do you identify a patient with acute pancreatitis who actually does need an ERCP? So effectively, how do you diagnose acute cholangitis in a patient with acute pancreatitis?
I think the most sensitive marker you look at is your PCT, procalcitonin. You can look at that as a laboratory marker. And Yeah, otherwise, I know the main indication for ERCP is a patient with cholangitis and biliary pancreatitis. But your question is how to diagnose that if you're not
Yes. How
100%
do you
sure.
diagnose cholangitis in a patient with biliary pancreatitis? Because your markers are going to be up anyway.
Yeah. No, I'm not sure.
Okay, so normally you have an LFT in these patients. So usually these patients, it's a larger stone. So the bilirubin and conjugated would be up, giving an idea that there's obstructive jaundice. The ALP and GGT would be up, but often they are up anyway, even with acute pancreatitis from all the other causes. But what's more important is that the LFT does not improve with resuscitation of the patient, and it tends to get worse, and their organ dysfunction gets worse. So in other words, in the vast majority of patients with acute pancreatitis who've got a deranged LFT, with resuscitation, once the pancreatitis starts to settle down, the LFT improves, right? In this case, the patient does not improve. So the bilirubin continues to go up. The ALP, GGT go up, but together with that, you have to diagnose cholangitis. So the AST and ALT are up anyway. So it's a cholangitic LFT. Those enzymes also continue to increase. It's that patient that needs an ERCP for the cholangitis. And what would you do at that ERCP if you now had one of those patients?
So
Are you going to remove the stone?
I would think so. Yeah.
No, minimal fiddling.
No.
You'd put a stent.
Stent. Yes.
You just put up a plastic stent, give the patient a chance to recover, because again, you don't want to worsen the acute pancreatitis. All right.
Yeah.
So it's a very carefully done ERCP. I mean, you have to be phenomenally careful that you don't get into the pancreatic duct, which obviously is easier said than done. And you also want to do as little as possible to that patient. So the easiest is that you just put up a plastic stent, let the patient go back to ICU, and then after a couple of weeks, you can always bring the patient back and then repeat the ERCP and take the stone out. VG, I see your hand is up.
Hi, I think since we're speaking about ERCP in this kind of setting, I completely agree. I mean, in the urgent situation, if you've got a patient who's got colon biliary, obvious biliary dilatation, colon laryngitis, and jaundice, early ERCP is okay. Can we just get some clarification now? What happens after the acute episode has subsided, and at some point somebody's performed your MRCP or a EUS or even your normal ultrasound, and you receive your report saying there is a stone in the CBD? At which point will you say, okay, now maybe I should go and do an ERCP to extract that stone, even if this individual is now at that stage where they are over the acute stage and they're starting to improve?
Okay. I think he has got slides coming a bit later on that, but do you want to answer that question now?
Okay, so in a patient where you have stones, okay, I think if we can just continue, and then if we don't answer it,
Sure. I think yeah, I'll hold on.
Sorry about that. Okay. All right. So when it comes to fluid resuscitation, there was a recent study called the Waterfall study, which basically showed that, according to the International Association for Pancreatology, they actually suggested that patients should be aggressively fluid resuscitated in the first 24 hours. And this study shows that that's actually harmful. The Waterfall studies showed that it was actually stopped prematurely due to patients developing fluid overload in the aggressive fluid resus arm. So that takes us to what the French Society of Anesthesia and Intensive Care Medicine, that they do not recommend aggressive fluid resus, but rather based on the patient's individualized hemodynamic response to fluid. So this was the study showing that like across the board, aggressive fluids are not indicated in these patients.
Can you give us an indication of what is aggressive fluid resuscitation and what is conservative? So, I mean, what would you recommend for a doctor who's got a patient who's come into casualty? The patient is a severe acute pancreatitis. How would you suggest that they begin the resuscitation, followed from your reading?
So basically, the conservative approach was you can give the patient. So the high volume approach was 5 to 10 moles per kg in the first 48 hours, which approximated about approximately around about up to 8 liters per patient. And I'm talking about the first 48 hours. And then the conservative approach was where patients got an overall fluid intake of between 3 to 5 liters. Those patients actually did better. So on the floor, one would start with fluid resuscitation. If the patient's hypotensive, you'd give them a bolus of fluids. And the preferred fluid was Ringer's lactate that had a better outcome. And people...
How much should that bolus be? Let's say you've got a patient who's my size, so around about 80 kgs. What kind of a bolus would you give? Maybe my blood pressure is sitting on 100 over 60. What bolus would you give me?
So it would be, I would start fluids at approximately 128 moles per hour with a 500 moles fluid bolus, and then see how your hemodynamics respond from that. If your blood pressure...
So the bolus in the study in the conservative group was 10 moles per kg.
Yeah.
So it's a little bit more than what you had. And then the maintenance fluid after you've given that bolus, and that bolus was only given if there was hypotension. Otherwise, the patients were given 1 mol per kg per 24 hours. So it's a very low amount of fluid, which is completely opposite to what we had previously. But I think that also, for me, one of the main messages that came out of that study is that it has to be goal directed. You need to look at your markers of resuscitation every 4 to 6 hours in these patients so that you adjust your fluids accordingly, and that it's no longer just a blanket statement that you prescribe the fluids for 24 hours and then reassess after those 24 hours, because some of those patients are going to be flooded and have pulmonary edema, etc., and others are going to just be under resuscitated and just worsen. Okay, cool. Thanks. You can continue.
Thank you. All right, so now we look at nutrition. So particularly in mild to moderate pancreatitis, there was a trial called the PADI trial, which showed that immediate refeeding resulted in a shorter length of stay, fewer costs, and fewer complications. And feeding tubes were only used in patients with persistent nausea, vomiting, and abdominal pain who do not tolerate olive feeds. When you go to severe acute pancreatitis, the concept of bowel rest, where the patient's kept in PO, has now fallen away. So the reason is because the injured acinar cells do not respond to physiological stimulation. So now enteral nutrition is preferred as soon as possible, and oral nutrition is preferred over tube nutrition if the patient can tolerate it. And the reason for this is it maintains gut integrity, it reduces the bacterial endotoxin formation, as well as the translocation of the pancreatic enzymes. So when compared to TPN, enteral nutrition was associated with a significant reduction in death, with a risk ratio of 0.36, and the organ failure rate with a risk reduction of 0.39. So it suggested that nutrition should be started after adequate resuscitation and the hemodynamics are stabilized. In patients that do require tube feeding, the suggestion is continuous feeds over bolus feeds. And nasogastric feeds have been shown not to be inferior to nasojejunal feeds in terms of pain, aspiration, and mortality. So TPN is only indicated for patients who have intestinal failure, obstruction, or severe ileus. It was also shown in the study that parental L-glutamine reduces mortality and morbidity. And also omega-3 fatty acids have been shown to be beneficial for reducing mortality, infectious complications, and length of hospital stay. Antibiotics, so prophylactic antibiotics are not recommended. It does not decrease mortality and morbidity. Once a patient has been diagnosed with infective necrosis, one would look at the procalcitonin as the most sensitive way to detect a new infection developing. So once you suspect that, the best option would be to get a CT-guided fine needle aspirate to get a specimen for MCNS and then directed antibiotics. So if gas is seen in the retroperitoneum, it's also an indirect indication of infection. So the choice of antibiotic must cover for gram-negative, gram-positives, and anaerobes. So that leaves us with piperacillin, tazobactam, carbapenems, and metronidazole. So these offer good penetration into the pancreas. Of note, aminoglycosides have poor pancreatic penetration. So we were talking about post-ERCP pancreatitis. So this occurs in 7% of...
Can I just take you back one slide? Yes. I think, as I was alluding to in our discussions over the weekend, this topic is changing. And there was a meta-analysis in which they did a trial sequential analysis published, I think Antibiotics is actually the journal. It was published towards the end of last year. And to my recollection, it was around about 20 studies that they eventually included it. And what is very interesting is what they found is that prophylactic antibiotics significantly decreased the sepsis rate in these patients. However, they went into what kind of sepsis, and it tended to be extra pancreatic sepsis. So, for example, there was a lot lower incidence of UTIs and things like that. There was no real change in the incidence of infected pancreatic necrosis. And also, there was no real difference once patients who needed surgical interventions, whether or not they were actually treated with the infected necrosis. There was also no real change or difference in those patients with the rate or the duration of organ failure. But where they did show a really big difference, it was a significant shortening in their length of hospital stay. So their conclusion was really that maybe prophylactic antibiotics don't necessarily decrease the incidence of infected pancreatic necrosis, but it decreases the risk of extra pancreatic infections, which resulted in better outcomes in the sense that there were shorter hospital stays. There was no effect on mortality, like you said. But I mean, I used to be someone who always used to preach completely that one should avoid antibiotics as long as possible, because we were very worried, obviously, that you get resistant organisms in the necrosis once it does develop, because it develops usually after 10, 14 days, etc. So it's just something to think about. And maybe one shouldn't be as strict as what we've been saying. The problem with the antibiotics that you've listed there, piperacillin or tazocin, doesn't really have such a great penetration. So it really is the carbapenems. Metronidazole doesn't either. So the two groups that really have good pancreatic penetrations are the fluoroquinolones and the carbapenems. The problems with the fluoroquinolones, obviously, is that they get very quick resistance developing in them. So we don't really use fluoroquinolones. So carbapenems would be the only choice. But so what I'm saying is this debate, unfortunately, around prophylactic antibiotics is going to come back now. So just be aware of it, especially for the guys who are going to write their exams and that. Because I am aware in academic circles, it's often debated, but in non-academic circles, everyone gives antibiotics. And so you're going to have to be able to advise your colleagues about which way to go. So cool. Okay, you may continue.
Thank you. All right, so post-ERCP pancreatitis occurs in 7% of therapeutic ERCPs, and in 25% of patients with sphincter of auditory dysfunction. So it's more likely to occur in patients who have normal duct anatomy. And the patient profile to describe this would be a woman with suspected choledocholitis and a normal bilirubin that underwent a sphincterotomy, and no stone was found. So 27% of these patients develop post-pancreatitis ERCP. So basically, if you have, the more abnormal your ducts are, the less likely you are to develop post-ERCP pancreatitis. And the diagnostic criteria we look at is where serum amylase is more than 276 and a lipase is more than 1,000 2 hours after the procedure. So if the values are normal 3 hours after the procedure, only 1% of those patients develop post-ERCP pancreatitis. There have been methods that have been proven to prevent it, which would be the use of prophylactic pancreatic stents and IV fluids pre-procedure, as well as rectal NSAIDs. When we look at hypertriglyceridemia induced severe acute pancreatitis, the hypothesis behind it is that the elevated free fatty acids and chylomicrons increase the plasma viscosity, which then would reduce the perfusion to the pancreas and then induce ischemia and then trigger the inflammatory process. The other hypothesis is actually where patients have this high free fatty acid concentration, and then the chylomicrons that are usually taken up by albumin become saturated, and then you have a lot of free fatty acids and chylomicrons that have a detergent effect on the pancreas, and then that then stimulates the inflammatory process. So if the triglyceride level is more than 11.3, one would consider it as an etiology for the pancreatitis. And the triglycerides do rise naturally in acute pancreatitis that may cause a false elevation. And then also the levels drop approximately 48 hours after the onset of pancreatitis. So the diagnosis can be a bit tricky depending on where the bloods are taken. However, if you have prior blood tests done or earlier blood test after the patient becomes symptomatic would be the most accurate. Also, the amylase and lipase levels can be falsely reduced due to assay interference by the hypertriglyceridemia itself. Okay, so when it comes to treatment of hypertriglyceridemia-induced pancreatitis, one of the options is plasmapheresis, and this rapidly reduces the triglyceride levels. However, we're limited by cost and poor availability. And there's also limited evidence showing that it reduces mortality and morbidity. Medical treatments would include insulin, which activates the lipoprotein lipase, and it reduces the chylomicron levels by that enzyme activation. Unfractionated heparin also has the same effect. One could also use fibrates, and now there's novel gene therapy, which include MRA-related therapies. So if you have acute pancreatitis in pregnancy, the incidence ranges between 1 to 1,000 and 1 in 5,000 pregnancies, with a death rate of up to 37% in the mother and a fetal death rate of 60%, up to 60%. It most commonly occurs in the third trimester of pregnancy, and a third of these patients develop severe acute pancreatitis. The top three causes would be cholelithiasis, alcohol, and hypertriglyceridemia. So pregnancy itself increases the risk of cholelithiasis. So in the first trimester, changes in pregnancy causes the change in bile composition, essentially is an increase in the cholesterol content. And then that leads to the increased risk of gallstone formation. And then also the effect of progesterone itself on the gallbladder and bile duct contractility leads to duct malfunctioning. And then If you add vomiting from pregnancy, that leads to dehydration, and then further concentration of bile. So all of these factors increase your risk of bile stone formation. And then your stone formation occurs, and then that increases your risk of pancreatitis in the second and third trimester. So management, we aim to be as conservative as possible. However, if surgery is indicated for acute gallstone pancreatitis, there's a debate between open or laparoscopic cholecystectomy. And compared to open surgery, laparoscopic intervention is preferred because it reduces the time of surgery, the length of stay in hospital, wound and other complications. Post-operative pain is less, and the incidence of thromboembolic complications are less, together with post-operative intestinal obstruction. However, with laparoscopic surgery, you'd be limited by the presence of the gravid uterus that may obstruct your port or camera views. But if a patient does require surgery, the second trimester would be the best time to perform a laparoscopic cholecystectomy. And the ERCP is indicated only for patients with symptomatic cholelithiasis. One needs to bear in mind the risk of teratogenicity from the fluoroscopy and further malignancy risk in the child or in the baby due to the X-ray exposure. One should also remember
Okay, sorry,
to
let's
counsel
just
the
go back
patient.
to your previous slide. So
Yes.
let's say you've got a lady, biliary pancreatitis, first trimester. What is your plan? So let's say she's just a mild acute pancreatitis, but she's a mild acute biliary pancreatitis.
Okay, so if she does not have any signs of cholangitis, you'd want to treat her conservatively as far as possible.
But now, are you going to leave her for whole pregnancy with a gallbladder in situ so she can have a recurrent pancreatitis, and then maybe in third trimester she's now severe?
So I would try to buy time until at least the second trimester, where we would then consider a laparoscopic cholecystectomy, because the uterus wouldn't be as large as in third trimester.
Okay.
Yes.
Yes, I would tend to agree with you. We can do lap choles in the third trimester. It's not the size of the uterus that's prohibitive, because I mean the uterus never reaches the liver. So, but it's more the problems of having the patient lying supine and all of those that are the issues there. But at the end of the day, one can actually do a laparoscopic cholecystectomy in any trimester. The teratogenicity period for, especially with anesthetic agents, is usually up until around about 8 to 10 weeks. So one has to be very careful, because there's a high rate of fetal loss, and then there's also a high rate of premature labor in these patients who develop pancreatitis in their pregnancy. So it's not always a straightforward not a straightforward clinical question to answer. I think the vast majority of these patients should have their lap chole during the second trimester, because there is a substantial risk. And I think there are a few publications out there that have shown the rate of recurrent acute pancreatitis in a patient who is pregnant is quite significant. It's in the order of 15 to 20%. So it is not without its own risks. So one shouldn't be too blasé. So I wouldn't say if indicated. It is indicated. If you've got a documented biliary acute pancreatitis, a cholecystectomy is indicated, and it should be done in the second trimester. Okay, cool.
Thanks. I just wanted to speak about the counseling. One should remember to address these etiologies while the patient is admitted for alcohol and smoking. But if one looks at other interventional treatment, okay, we spoke about cholecystectomy for cholelithiasis. So the risk of recurrence if a patient, after the initial event of severe acute pancreatitis, is 18% in 6 weeks. So therefore, the recommendation is for it to be done during the same admission. The same goes for a patient who has a gallstone in the CBD should have an ERCP with sphincterotomy. So the urgent ERCP is indicated in patients within the first 72 hours of acute biliary pancreatitis. So that would be patients with cholangitis or persistent cholestasis, and if there is a stone in the CBD. If there is no cholangitis, then the mortality rates and complication rates do not change with conservative treatment. So basically the major indication would be cholangitis. Okay, so when you look at fluid collections, you have your acute necrotic collections, which form less than 4 weeks after onset, and they involve the pancreatic parenchyma and surrounding tissues. So they usually contain necrotic fluid and enzymes, and they can resolve spontaneously. More than 4 weeks, you get walled-off necrosis, which is a mature encapsulated collection of pancreatic tissue or necrosis. So drainage of these collections are indicated if there is infected necrosis, if that encapsulated mass is causing obstruction, or if the patient is having systemic effects of that collection, which may be manifested by loss of weight and debility. And if there's disruption of the pancreatic duct, which we would use our MRI to find, and if there's a fistula that's forming between the bowel and that collection. So the options that we have are the percutaneous method with pigtail drainage.
Sorry, I'm going to just stop you. Can you just go back to your previous slide? So the indications for drainage are becoming more and more conservative. So just because there's an evidence of infection doesn't necessarily mean that you're going to do either an endoscopic or a percutaneous drainage procedure of the necrosis. I think there was a systematic review, which was also published last year, where they actually showed that the majority of patients with infected necrosis actually responded to antibiotics and did not require necessarily drainage. So it's really the patients who've got an infected necrosis and who are systemically unwell and not responsive to antibiotics. So again, similar to that situation where we were talking earlier about the patients who are not responding to best medical therapy. And what so if you give the correct antibiotics, so here again, you would give a carbapenem. And if the septic markers don't really improve, the patient continues to become hemodynamically unstable, their renal dysfunction becomes worse, etc. So they get organ dysfunction, then you need to do an intervention. Causing obstruction, I would agree with. So in other words, these are collections that give you either a gastric outlet obstruction or obstructive jaundice. Very rarely would they give you a small bowel or a large bowel obstruction. Systemic inflammatory effects and loss of weight and debility, that would really only be because they have an obstruction. So it would fall in with the previous one. Pancreatic duct disruption is not so straightforward. It depends on the patient as well, because ideally, if it's a young patient and they've got a pancreatic duct disruption, we would prefer to do a central pancreatectomy or even a distal pancreatectomy for them. Because obviously, if you're going to do a drainage procedure, so for example, you do an endoscopic ultrasound, you drain the collection into the stomach, so you're creating a fistula into the stomach. That fistula over time can still close. It can still get secondary infection, etc. So it's not really a great definitive procedure, especially in the younger population. In the patients who are maybe a little bit older, who have got significant comorbidities that maybe a surgical intervention is not appropriate, then they obviously, you don't really have much of a choice. And then there you should see that you create a fistula into the GIT tract. So just be careful of that. Fistula formation, it depends what kind of a fistula you're talking about here. Probably the most common one here would be, that is symptomatic, is an intrapancreatic fistula. Pancreatic or cutaneous fistula, sorry. Because if it's an intrapancreatic fistula, then so what? Then you have to wait and see if the patient then gets sepsis because of that, then you have to go and consider doing a central pancreatectomy. Okay. So I think the message should be that for fluid collections, we virtually never do anything in the first 4 weeks because we want them to mature. And if we are going to do something, we let them mature for as long as possible. And then we only do something if we really have a hard indication. And probably the most common hard indication are two. The one is infected necrosis with a patient who's not improving on antibiotics, or it's causing a mechanical obstruction, such as a obstructive jaundice or a gastric outlet obstruction. Okay, thanks.
Thank you. All right, so the options that we have for drainage are the percutaneous pigtail drainage, the endoscopic gastrostomy with pancreatic necrosectomy via an expanding metal stent. And I found that the endoscopic drainage was preferred over radiological drainage because the risk of a percutaneous fistula was reduced, and surgery has a higher mortality and morbidity. There's also the option of a laparoscopic pancreatic necrosectomy and then the open pancreatic necrosectomy. I just included some images to give the viewers a look at how the gastrostomy, and then it goes through into the fluid collection via the endoscope, and then the necrotic parts are then removed. Here's another image showing the access route retroperitoneally, and here endoscopically again, performing the necrosectomy. So the indications for open surgical intervention include the abdominal compartment syndrome, a patient with ongoing bleeding when endovascular approach is unsuccessful, if there's bowel ischemia or acute necrotizing cholecystitis during the acute pancreatitis, and if there's a bowel fistula that's extending into a peripancreatic collection, and any unsatisfactory result from a percutaneous or endoscopic procedure. So the complications of the, yes.
Go back quickly to that slide. I think open surgical intervention is associated with significant morbidity, and if it's an early acute pancreatitis, with a significant mortality rate. So one has to be very careful of it. So I think we've spoken about abdominal compartment syndrome. Acute ongoing bleeding from an endovascular approach. This is not usually in the acute phase. It's usually patients who've developed pseudoaneurysms. So it's usually patients who've had it for a while. So I would agree with that. If you're lucky enough to be able to intervene with an open procedure in these patients and that they can survive. The bowel ischemia, acute necrotizing cholecystitis, again, that's usually the acute phase. Remember that second indication for a CT scan in the early phase of pancreatitis. This would probably be that example. Again, this is associated with a very high mortality rate. And those kind of discussions must be had with the family, because usually these patients are already intubated, etc. Unsatisfactory result from percutaneous endoscopic procedure. Again, it depends on the timing. If it's too early, one can really snowball the patients into a massive CARS response from which they may not recover. So I think my message is here, again, be very cautious for the open surgical interventions, because they have significant morbidity and mortality in the face of acute pancreatitis, in acute pancreatitis. Okay, thanks. You can continue.
So the complications, it's your upper GIT bleeding. So the Mallory-Weiss stay from vomiting, peptic ulcer disease from the ICU stay. You can get the portal of systemic or splenic vein thrombus due to the nearby inflammation that can then lead to esophageal varices and then bleeding. You can get pseudoaneurysm formation, and then you can get hemosuccus pancreaticus. And then we also spoke about the abdominal compartment syndrome. And then long-term, you can get endocrine insufficiency. So 15% of these patients can become diabetic at 12 months. And then you can get exocrine insufficiency, where 40% of those newly diagnosed diabetic patients can then have malabsorption from exocrine insufficiency. So this is a CT scan showing a pseudocyst as well. And this is just a list of complications that can occur. And that's my references, additional references. Thank you.
Great, thanks.
Any questions?
Well done. That was a very big topic to cover, and you managed that in an hour. Very impressed. Well done. I think we've answered the questions in the chat room. Is there anyone who wants to raise their hand and ask a verbal question or an oral or whatever? Not sure the correct term would be. I'm not seeing hands going up. Okay. Okay, great. I think then we are pretty much done. If everyone could please just fill in the feedback form. Oh, hang on, I see a hand up.
Hi, Barton.
Oh, it's you. Hi, yes, Vidi, go for it.
Yeah, just a quick one, going right back to the start. Amylase versus lipase to make the sort of a diagnosis of acute pancreatitis. Is there any role for amylase anymore, or should we just be ordering a lipase?
I think we should just be ordering a lipase because it's so much more specific. But I'm aware that so for example, in our hospital in Pretoria, we can only order lipase nowadays. The lab has discontinued amylase, but I'm aware in the smaller hospitals, I'm not sure if that's in your neck of the wood as well, but in Mpumalanga and Limpopo, the smaller hospitals don't have lipase. They can only do amylase. So I think that's probably the reason why we still teach amylase and lipase, but you're correct. And one must really keep in mind the two peaks. So the amylase tends to peak around about day 3 to 5, and then it tapers off. And then whereas the lipase is about 2 days later. And typically these patients don't often arrive on day 1 or 2. They usually arrive on day 5 or 6 because they haven't got any better. But if you have a choice, lipase all the way.
One of the reasons why I'm asking is because there are places where you can do amylase and lipase, and frequently we see both being ordered, the amylase and the lipase. And the other thing to try and sort of clear up is the role of doing serial amylase or lipase.
Yeah.
Any role there that I'm unaware of, because I also can't see where it fits in, because somebody has high amylase and then a few hours or maybe 2-3 days afterwards, somebody decides to do a repeat amylase and say, the amylase is improving, so that means the acute pancreatitis is improving. And then the other thing is the role of CRP in acute pancreatitis.
Rahm, do you want me to answer these questions, or do you want to give a bash?
Okay, so the first one was the sorry, what was the first one again?
The role of amylase. Well, we know we can make a diagnosis, but then doing serial amylase results, any role at all? I
don't think that's helpful. I don't think that's helpful because the half-life is 12 hours, and we do know that the levels do drop after the initial event. So I don't think it's helpful once you've got your diagnosis. Yeah, that was the first question.
CRP.
Let me add that before you answer the CRP. There's no prognostic value whatsoever with the level of the amylase or the lipase. A patient who gets diagnosed with a lipase level of 1200 compared to a patient who has a lipase level of 400, their clinical course is totally different. It's not dependent on the level of the lipase. So there's no prognostic value whatsoever, and it cannot be used in any way to see if your treatment is working. So both amylase and lipase are purely diagnostic tests.
I completely agree, but it's actually something that you actually see out there. So just wanted the fellows that these are the things you hear about in the ICU rounds or in the ward, and just to be wary that there's no evidence of it. And the CRP, either Rahm or in Martin.
Go for it, Rahm.
So I don't think, okay, so one would, so the serial CRPs, I think the only use, well, the procalcitonin we discussed was more sensitive for detecting infective necrosis. So that would be more sensitive if that's what you're looking for. But CRP, if you're looking for that, I think it would just be like a screening test to look for sepsis from either infected necrosis or another cause like a urine tract or a respiratory cause.
Let me help you there. I think CRP is a very valuable test. You cited the Santorini guidelines, and the Santorini says that you should look at the CRP 48 hours after admission, and a value 48 hours after admission with a greater than 150 is a prognostic marker, and it tells you that your patient may be in trouble. But it doesn't change your management at all of the patient. So, I mean, what we're seeing more and more is with obesity, as we know, pancreatitis is in the retroperitoneum. Obese patients have a lot of fat in the retroperitoneum, and that is a driver for your acute pancreatitis. So you might have a patient who comes in, is classified as a mild, but the CRP is already high. So maybe it's 120, maybe it's 130. Those are the patients that you should do serial CRPs on to see what the trend is. If that trend continues to go up, and especially if it's more than 150 after 48 hours, it is actually a very good marker to tell you that this patient is potentially going to be in trouble. And in our practice, we wouldn't discharge that patient very early either. We would tend to keep them for at least 5 to 7 days, even if they are tolerating full ward diet, walking around the ward, just to keep an eye on them, because we know that they're more prone to getting a second hit. If you already have a very high CRP, so let's say you have a patient comes in, maybe they're a severe acute pancreatitis, you do their CRP and it's 200 or 300. You already know that there was a significant SIRS response. You want to see that your treatment is actually working. And if that CRP doesn't come down after 24, 48 hours, it again is a marker that your patient may be in trouble. It doesn't change how you're treating the patient, but it just makes you more aware that you've got a patient who either is not responding, even though maybe their other numbers are, or they're at risk of developing complications. And so it's just, for me, it's just a warning bell. It just says, look, be careful, my pancreatitis is still brewing. So CRP is actually quite a valuable test. Thanks, Vijay. Are there any other questions? Because I see we've now run 10 minutes over. If anyone is still thinking of their question, could I please ask the audience, just fill in the survey. It gives us information about what we've done well, what we can do better in, etc. It really is quite valuable. It is in the chat room. So before you log off, please quickly go and fill in that survey. It really does actually help us improve what we are doing in these lectures. And then I think, again, I would like to thank you, Rahm. It was really a well-done presentation in such a short period of time. You touched on all the important points, so well done there. I would also like to thank the EHCO team in EHCO India for their support. The recordings will be available on our website, the Gastro Foundation website, together with the presentation. And again, we can never thank the Gastro Foundation enough for all of these opportunities that they give you guys. I find these talks are really fantastic. So the next presentation is on Monday, the 24th of July. The topic is pancreatic cysts. The presenter is Dr. Ionela Kwebekile, and Dr. Burmeister will be the moderator. So once you've finished filling in your survey, I hope you all have a good evening, and then we'll see you back on the 24th. Thank you very much and have a good evening. And thank you very much, Karen, for all the help. It was much appreciated.
Thanks, everyone. It's always great to see these presentations. See you in 2 weeks' time.
Okay, bye.